These are patients with fairly poor substrate. So this in particular is a patient who had an MI and later on went on to develop ventricular tachycardia episodes for which an implantable defibrillator was placed. He went for several years with increasing episodes of VTAC. He underwent a catheter ablation, and this was done on extracorporeal membrane oxygenation, and so in other words, not on a ventilator, where they actually took his heart-lung circuit out so that you could get everything still. This patient experienced something like 1,200 episodes in a 3-month period prior to me irradiating him of either ventricular tachycardia, ventricular fibrillation, need for shocking, need to pace out of it. So 1,200 cardiac events in a 3-month period. We mapped the area of trouble to the heart to an area near the septum, and you can see here, this is heart, left is right and right is left on all these scans. This is the implantable defibrillator lead going into the ventricle. And you can see this is 2,500 centigrade, 25 gray to the heart. The entire heart receives 50 centigrade. Much of the heart receives between 1,000 and 1,500 centigrade. The entire thoracic cavity at that level is receiving 50 centigrade. And you can see again what that dose distribution looks like in 3 dimensions. This patient, when I had treated him, was an inpatient on a lidocaine drip, unable to come off the drip because he was experiencing multiple shocks a day. Within 24 hours of his treatment, he was off the lidocaine drip. Within a week, he was home. He is currently home, and his post-radiation events in 3 months, he had one pacer-related event where his heart had to pace back to a normal rhythm instead of 1,200 in the following 3 months. He is currently alive and well a year and a half after this radiation dose, and he is almost completely off antiarrhythmics and having no cardiac events per 3-month period at last follow-up. So again, tremendous radiation dose to the heart, and a person with very poor substratum who at a year is not experienced any significant myocardial toxicity. Thinking about what else we do, again, hard to understand radiation toxicity to the heart in patients who have lung cancer. A little easier with something called thymoma. So this is a cancer of the anterior mediastinum, which can be resected, but typically there's difficulty with the resection for more advanced cases where you have to kind of peel it off the vessels, peel it off the heart. This is a 40-something-year-old female, so a premenopausal female who is an active mother and lawyer who I radiated post-operatively. You can see here again the doses of approximately 60 gray. Much of the anterior heart is receiving that dose. A lot of the mediastinum, and again, you can see the potential benefits of protons in particular for reduction of breast radiation and reduction of lung radiation, but still the heart here gets a tremendous dose. She experienced essentially some redness of the skin that went away. There's no fibrosis. She has to date experienced no change in her exercise capacity, and she's actively continuing to work. But these are potentially a interesting set of patients to study because these are more what you would consider astronaut quality, but folks that are young in their prime, that are healthy, who have a cancer that is potentially easily curable, will live a really long time, and is treated only with surgery that doesn't seem to have any significant cardiac effects. So this is a population of folks where you would not expect any real cardiac disease or cardiac outcomes that could easily be measured for dose tolerance. Other things that we can do, this is a physician with a malignant thymoma that had spread to the entire pleural surface. We went in and did surgery and removed all of the thymoma. However, it was multifocal invasive into the chest wall in multiple locations, and we decided to go ahead and treat him with hemithoracic radiation. So this is a therapy for which you essentially radiate the entire pleural surface, as you can see here, with an attempt to spare the lung. At 50 centigrade, you can see essentially half of the thorax and a good portion of the abdomen are getting 50 centigrade. If you want to see the sparing of the lung, we are actually able to effectively spare the heart and lung. The highest doses from this part of the heart, but again, the entire left ventricle gets these kind of doses. Had some pneumonitis, for which we used steroids in the post-radiation period. He recovered very well and is continuing to practice medicine on a full-time basis. We are now increasingly treating patients with either isolated metastasis or very early stage lung cancers with stereotactic radiation. And again, so you can see what this looks like. This is a highly focal form of radiation where, again, very little radiation goes to the rest of the chest, but still, you can see there is a significant radiation dose. That's percent, that's why. Here we go. My apologies. Let's set that to 50 centigrade. Here you can see again in these patients in the plane of the arc that we're treating, the majority of the heart-lung circuit receives a very significant dose. And finally, again, this is a patient with a early stage liver tumor that you can see with IMRT. We're able to spare the majority of the organs, although again, significant quantity of both the heart and upper abdomen receive a significant dose. So this is the kinds of things that we're doing every day in radiation to fairly high functioning patients. These are the kind of doses we're giving. Certainly patients do experience toxicity, but the overwhelming majority of them who are able to go back to work with their cancer are able to go back to work as fairly high functioning professionals. So I think this is potentially instructive when we think about dose and risks. So much of this is with photons or protons. Much of this is with fractionated radiation, where the dose is spread out over somewhere around 2 weeks to a month to get this high dose. It's given in a fairly complex dose rate where there's a very small peak of dose that's then given every day. How well this might model the space radiation environment is difficult to understand, but certainly I think instructive in terms of the risks that we're talking about. Certainly, we also do see second malignant neoplasms from radiation, but these are exceedingly rare outside of the pediatric population. So with that, we're almost done. Want to talk a little bit about particle identity effects and dose rates. So again, up to this point, we've been talking about photons and protons. The extent to which these adequately mimic the space radiation environment when we're talking about iron ions or other heavy particles is difficult to understand. Perhaps instructive to think about neutrons. I know right now we're thinking a lot about low dose rate chronic neutron facilities, and I guess from the radiotherapy world, I would just add a note of caution for the unknown. Neutrons have historically been difficult for two reasons. They are very difficult to control in therapy in terms of charged particles are much easier to corral and give the dose where we want, when we want. So the spatial control of dose is much more exquisite with any charged particle than it was with neutrons. And that's certainly been an issue over the years that really has made neutron therapy not nearly as effective. But beside that, I will tell you from experience, I have a small cadre of patients that are long-term follow-up for neutron trials still left, and certainly have seen a lot of these patients over the years. The quality of fibrosis that you see in subcutaneous tissues, the quality of other side effects, vascular side effects that I've seen in these patients doesn't appear to be a linear scalar multiplier of dose. So typically these patients are treated with about a third of the dose, physical gray dose with neutrons compared to photons. And when you do these, we ran a bunch of randomized trials over the years. You can see certainly neutrons were capable of improving local control, especially in tumors that were thought to have a significant hypoxic fraction, such as some head and neck or prostate patients. But again, if you look here, the major complication rate, now these were with doses that provided improved tumor control and potentially reduced acute responding tissue toxicity. But in late responding tissues, we're seeing major increases in toxicity from neutrons. It's one of the reasons we really don't use them much anymore. Again, late toxicity by treatment arm. This is skin, subcutaneous tissues, mucous membranes with very significant increases in late toxicity. I point this out to say, from clinical use, what we learned about neutrons was that a neutron isn't a multiplier of a photon. It is just a different beast entirely. It has a different set of radiobiology that applies to it in terms of both acute and chronic toxicities. And that's one of the reasons we've been very attracted to protons in general in therapy, where we've done pretty well just taking 10% off to get the dose we want and understand the radiobiology. I'll also point out we've now done this with carbon ions, and increasing evidence suggests that a scalar multiplier factor that's LET dependent of around 3 at the highest LET with carbon ions has not produced these very similar toxicities. So again, even with a heavy charged particle, heavier charged particle like carbon ions that does have a very significant increase in RBE toward the end of the track length, these scalar multipliers or of LET versus RBE seem to pan out very similar to photons, whereas neutrons seem to be very dissimilar for reasons that are not at all clear. And I would, I guess, say this is my clinical note of caution for low-dose rate neutron facilities. What we learned about neutrons is they're really hard to understand. Their radiobiology is really complicated, and it's possible that it is very dissimilar to heavy charged particle side effects, radiobiology, toxicity, what have you. And I would so add a note of caution. It is clear that low-dose rate neutron facilities are going to give you data on low-dose rate neutrons. To the extent that low-dose rate neutrons are definitely an issue because of shielding in the space radiation environment, that's going to give you good data, but I would definitely caution about extrapolation to heavy charged particles. Other thing about dose rate, again, we've talked about punctate dose rate today, mostly given over 30 days instead of a very chronic low dose rate. It's not clear what extent things are spared. I'll also point out there's still some room left for mystery in dose rate. This is a paper we've just published in the Red Journal earlier this year. For those of you who don't know, all the rage now in radiation is this flash dose rate. It's in all caps, but it doesn't stand for anything, which is kind of disappointing to me, but I didn't coin the term. So this is dose rates exceeding 100 gray per second. We have now delivered this to both mice and dogs with cancer, and we're verifying that at these ultra fast dose rates, first of all, done a lot of dosimetry work. The physicists are tremendous here, giving us the ability to deliver these in an accurate fashion. You can see here the long-term cure rate is very similar. We've done this now. This is a pancreatic cancer model, but we've done this in 5 or 6 tumor models. And again, I've done this in canine osteosarcomas in a clinical trial. And it appears that it does not spare the tumor whatsoever. But here you can see this is gut fibrosis. The light blue is collagen deposition in the gut. This is the standard radiation at 18 gray. You can see a very significant amount of fibrosis occurring, obviously very different than the fibrous tissue in the normal gut. Here it is this much smaller amount of fibrosis occurring. And again, you can see this quantified here. So just changing the dose rate to a very, very fast dose rate spares normal tissue long-term complications. Short-term, these are crypt cells, these are stem cell reproduction, stem cell growing stem cells in the gut. And you can see here again, this ultra-fast dose rate spares the crypt cells, spares fibrosis, doesn't spare tumor. And our radiobiology in terms of dose rate doesn't have a mechanism for why this should be so. And the sort of trivial explanation of hypoxia, at least, certainly does not encompass everything that we can see. So I guess I would leave this slide up as a reminder for clinical medicine, something I tell all of my residents when they start and all of my radiobiology students when I start their class. There are more things under heaven and earth than are dreamt of in your philosophy. So again, an opportunity for us to think about how clinical medicine might apply, but also some cautionary notes on how we're going to extrapolate these data and the limitations of models and understanding. And with that, and perhaps 8 minutes early, I am social distancing with my many children at home, coming into work for clinic here and there, and I will stop for questions.
Thank you very much, Keith. My name is, my name is Jeff Willey. I am the director of the Red Risk School. I apologize for how things were started off. We are having some technical difficulties as things tend to go these kind of challenging times as we're figuring things out from home. But I wanted to thank Dr. Cengel for that presentation and for giving the first talk of the Red Risk School. Many of you participants have been part of the previous two Red Risk schools in which we've talked about high priority risks to human health and space. And certainly radiation represents one of those high priority risks as outlined by the Human Research Roadmap. I think this is a fantastic talk because some of the risks that astronauts may face are degenerative risks of radiation in terms of cognitive decline, cardiovascular effects, promotion of secondary tumors. And so Dr. Cengel touched on those. Just as a brief introduction, Dr. Cengel is an associate professor of radiation oncology at the Perman School of Medicine at Penn, and clearly an expert in radiation oncology, thoracic oncology, and treatment using protons and photodynamic therapy. But also was a former leader in the Center for Acute Radiation Research, which was funded by the NSBRI. So also an expert in spaceflight radiation research. So I think we're really glad to have this talk. And I think it's a very nice lead-in to tomorrow, in which we're going to be discussing different radiation facilities for those of you who have any interest in performing these. And again, a goal of the Red Risk School is to broaden the number of people performing spaceflight radiation research. Tomorrow, we're going to be talking about a number of facilities performing simulated spaceflight radiation work where you can go to do your research, and neutrons are available at 2 of those. So there were a number of questions, and I'd like to read many of those. I'm going to start off by asking you to give your thoughts on acute central nervous system effects, cognition specifically, due to a solar particle event. So we talked about clinical radiotherapy and the dose distribution. What are your thoughts about a solar particle event and how that may affect CNS?
So the solar particle event is actually an interesting issue. So it's sort of normally when we talk about space radiation environment, we're talking about low dose chronic risks. And when we think about the solar particle event, now we're talking about potentially higher dose higher dose exposures. We're also talking primarily about protons as opposed to a combination of protons and charged particles. And so one of the things we actually did with the car was to start thinking about what these effects might be. What are the acute effects? Obviously, you need to know what's going to happen in a solar particle event in the first 24 to 48 hours. And the huge sort of major concerns were things like vomiting in a spacesuit, these sorts of things. But also, we were concerned with measuring cognitive decline. I will tell you, one of the things that's hard to measure in terms of acute effects is that whenever you have, especially in animals or in humans, a acute event that causes trauma or causes excitement or causes all sorts of things, the biobehavioral folks will tell you there's a disruption of everything: long-term memory, attention, detail, recall. All of these things, critical thinking skills, are strongly affected by any kind of a traumatic event, regardless of whether it involves physical trauma or not. Certainly that's true in mice, and what we found, at least in our studies, was that for the first several days, anything that was happening at radiation doses that would be probably achieved from a solar particle event were masked by just the action of radiating the animals. So having to take them down to the radiator, disrupting everything that you do. So that certainly disrupted learning, memory, performance, all these other things tremendously. So I think that's one huge issue with that. I also point out one of my favorite stories I tell my radiobiology student about time to vomiting. When we talk about time to vomiting, this was a thing we did in radiobiology for years and years and years. We could use this as a surrogate for dose, and we measured this in animals, and we found ferrets vomit, and we do all these great studies in animals, and then we go to Chernobyl, and what happened? And I tell my students, if I told you, everyone in this room, you had just been potentially lethally irradiated, can't tell you yet, you might die sometime in the next 2 months, and there's nothing I can do. About a third of people throw up immediately upon hearing that. And so, again, with measuring performance in humans compared to animals, these things become very difficult because you get all of these other things with human consciousness that are involved. In terms of longer term effects, for doses below a few gray, at least with protons, from CNS effects, we get these kind of scatter doses to the brain from patients who get proton radiation anywhere above here fairly frequently, and don't measure anything over and above the trauma of being a cancer patient coming in for radiotherapy.
I think that brings up an interesting point. So the neurocognitive effects could be in part due to anxiety, depending on the dose that the astronaut may have received, or just the possibility, which I think just goes to speak that anxiety on long-term missions certainly is in itself a confounding factor. And these combined hazards that astronauts are going to face, radiation, microgravity, anxiety, stress, lack of sleep, really in models should be examined together.
Absolutely. And I will say again, everything that I'm showing here is patients that are under some level of stress and everything else, and they've had all sorts of other insults, but none of them are in space. None of them are in the extreme social isolation of being in your living room on the way to Mars, basically, with 5 of your best friends. And none of them are in hypogravity and all the other things that come along with spaceflight that make it really challenging to think about at all.
Here's a question regarding damage to the brain, and the fact that there's the data is not out there in terms of humans, in terms of neuroregeneration once a person has cognitive deficits. But is there anything that can be done? Like, is there any physical therapy, any kind of treatments that can be done to mitigate some of these effects?
So, obviously there's radioprotective things. So we've used memantine in patients getting radiation up. This is a Alzheimer's drug that seems to protect the brain. The difficulty is, in and of itself, it also causes you to be slow thinking and fatigued. And I've really not been very impressed with our ability to get that dose into patients without causing side effects from the medication itself. In terms of other stuff, there was a lot of this stuff about brain games and brain training. Not a lot of that is panning out. I think the thing that probably is the most helpful is probably stuff like breath control. I think one of the patients was one of the folks I saw a chat thing come up about meditation and breath control. Mindfulness is huge. We do it a lot with our cancer patients. There are data that 3 deep breathing sessions of 20 to 30 total deep breaths per day has more impact on hypertension than single dose or single agent blood pressure medication. So these are tremendously powerful. We know that the neuroinflammation that happens in the response to whole body radiation, so you don't just have to get your head radiated, the body gets radiated. All of that is vagally mediated. The vagus is the primary mediator of neuroinflammation in response to all sorts of things in the brain. It's a primary mediator of biobehavioral deficits, changes to the hippocampus, changes the amygdala, all of these things that are going on. Mindfulness, deep breathing, meditation is all about controlling your resting vagal tone. And there's actually quite a lot of data on that from the physiology literature suggesting it could be tremendously helpful.
Well, along those lines, there are a number of the attendees who I know are interested in medical countermeasures that relate to spaceflight, as well as can be applied here on the Earth, potentially in clinical radiotherapy, obviously. Now, a number of people have looked at things such as curcumin as a radioprotector in different organs. Although I just like to say that it's also been shown to perhaps promote cancer as well, just in different studies. So, curcumin in itself looks like it has benefits, but there's also potential risks, and it depends on the studies. And also there's other, dietary countermeasures like the ketogenic diet. Do you have any thoughts on some of these countermeasures?
So I've personally tested curcumin. We have flaxseed lignans. There's actually now a contract with BARDA looking at those. We've tested those in humans. And again, it's an interesting thing. Certainly there are evidence that they mitigate behaviors and other toxicities in mice. Another interesting story though, flaxseed, we were giving whole grain flaxseed to mice, showing major mitigation capability with just dietary flaxseed. It turns out it was about 30 grams a day, human equivalent, meaning several tablespoons of flaxseed, ground flaxseed meal. So we were pretty impressed with ourselves for the fact that this was something you could easily incorporate into a human diet. When we put it in clinical trials, we put it in flaxseed muffins and learned that our CTRC is not very good at baking muffins, so none of the patients would eat them. So we then decided to give it to them as just whole grain flaxseed to sprinkle on stuff. Again, can work, but we had a significant dropout rate due to rectal ulcers or anal ulcers and fissures. So the flaxseed has, 15 grams of fiber and 20 grams of oil and 40 grams of stuff, which is very moving. So obviously, dietary countermeasures can make a hugely important contribution, but need to be treated with a little bit of caution. But certainly, if you can incorporate small amounts of them in the astronaut diet and they like it, it is not, it's not likely to be harmful.
In terms of regions of the brains, and you touched on this a number of times, but we were hoping you could maybe summarize this. An individual wanted to know, what are the brain regions that are really thought to be the most and the least sensitive to whole brain radiotherapy?
So the way the nervous system works in general in terms of toxicity is the more central you are, the worse it is. So as you come off the brainstem as a cranial nerve and start to become a peripheral nerve, as you come off the spinal cord and become a peripheral nerve, you're fairly radiation resistant and the effects are pretty minimal. The roots and the trunks coming off the spinal cord or off the cranial nerves as they sprout out are a little more sensitive. The cord is a little more sensitive still. The brain stem is a little more sensitive still. And then as you kind of climb up the brain, it gets more sensitive. The hippocampus and amygdala are certainly the area of the brain that has ongoing neurogenesis in adults, meaning there's growing cells. And we think that that is the most sensitive area. It is also the area where the vagal feedback and neuroinflammation has profound impact as well. So again, why do you experience fatigue? Why do you experience lack of appetite when you're not, when you're sick? Again, think about how that feels. It's not that you're not hungry. It's not that you're not energetic. It's that you don't really care about food as much, and you don't really care about activity as much. It's motivational priority and reprioritization. All of that occurs at the level of the hippocampus, and biobehaviors come from there. So I think that's the two reasons why it's the most sensitive to radiation. So it's the most sensitive place in terms of behavioral outputs from inflammatory inputs. And it's also got neurogenesis. The rest of the brain is not 100% clear. Obviously, the brainstem and the optic chiasm are two areas where we try to spare in radiotherapy, but these aren't doses that you'd ever experience. So I would say the rest of the brain is open to more speculation.
Here's a question regarding, in terms of your institution and using a gamma knife. Is there a limit to the number of METs that can be treated with a gamma knife? And also on top of that, and this question comes from me, if there's radiosurgical techniques, you're not just treating a MET in one blast. There's going to be some time that you treat the part of the tumor, and then you change to another part of the tumor, and so on and so forth. And so is there any indication that dose rate, because that is rate at which you're delivering these radiosurgical doses, can have an effect on outcomes?
So like a lot of things, and stereotactic radiosurgery is an area where there's sort of a bit of a one-upsmanship. So you'll see, originally there were a couple things where there was one or two lesions. Right now, we have good data in melanoma patients that treating up to 9 METs can actually improve survival. There are certainly series of 15 or 20. We sort of have an ongoing joke in chart rounds. We review all of our patients at chart rounds, and sometimes someone will mention it's whole brain gamma knife therapy, where a patient, when you look at a plan over either one session or multiple sessions, will have 20 brain mets being treated. We will start to see radiation necrosis, and we will start to see cognitive decline. We don't tend not to see those patients back for a long term, just because the kinds of things that give you the need to radiate 12 or 14 mets are not necessarily systemically survivable. But certainly, patients do get 9 or 10 brain mets irradiated. The dose to the rest of the brain is not inconsiderable. It's not something, if you would have asked me 20, 30 years ago, 20, 25 years ago maybe, I would have said it probably shouldn't be okay. And yet it seems fine. But clearly there are measurable deficits, but these are still people that are continuing to function at a fairly high level. Noting though, as you say, the dose is, say, 24 gray as a shot. That 24 gray might take 20 minutes to deliver with multiple shots from a gamma knife kind of thing. And so if you treat 10 brain mets, you're talking a 4-hour procedure during which all that radiation is received, and unclear whether that's a significant thing or not.
Thank you for that. Here's another question. In terms of the toxicity with neutrons, what are your thoughts about the timing? How soon do you see or are complications thought to occur after exposure to neutrons, because they are such a different beast than other forms of radiation?
You're giving me wonderful opportunities to quote my mentors. So Eli Gladstein, who also recently passed away, used to pound his fist on the table whenever we would talk about things, and he would say, "Late effects occur late," which is kind of obvious. It's been a Yogi Berraism, but yeah, late effects that we're seeing that are fairly profound. These are many years in the making. They're also at pretty high doses. I guess what I would just say about my experience with neutrons is I don't trust them. They're quirky, they're funny, they are very odd in terms of my experience with all other forms of radiation. Doesn't mean they're not a great model. That low dose neutron, hey, we need more data before we can complain about how applicable all of our data is. And I would say we have no way to give higher LET radiation at very low dose rates. So we can basically give gamma rays to animals at low dose rates and give neutrons. That's just the way the universe works. Anything that we learn in neutrons is clearly applicable because neutron dosing in space is a real thing for sure. I would just put a heavy note of caution about saying LET produces X effect, therefore iron ions are going to do exactly what this is. I think the value of them is much more in exposing the breadth of the qualitative differences. And this is what we talk about, this taking a 10% haircut on dose that we do for protons, where we just say, 0.9 times the gray dose is the effective dose. Those kind of scalar multipliers assume everything is identical, or the things that aren't identical come out of the wash. And I think the things we need to be most concerned about are qualitative differences, things that just simply won't occur with other radiation forms or don't occur in the same way. And I think neutrons at least give a window into that. I would just say heavy note of caution that they may be even more odd than other forms of space radiation, not less.
Okay, we have time for one more quick question. We've already talked about breathing and other therapies, and many of us have clinical trials in which we're looking at radioprotectors. Like we'll look at radioprotectors for bone. I know there's radioprotectors for bone and other things being used at different institutions. But clinically, what do you use that to protect normal tissues outside of behavioral? Perhaps if there are any pharmacologic agents.
So obviously we try to miss them and try to spread the dose out over time as much as possible as our number one agent. And that's what all that aiming stuff was about. For things like bone, we do use bisphosphonates. We do use the Rankle-based therapies as well. So that can mitigate loss of structure to bone to some extent. Other sorts of things we do in terms of mitigation are pretty limited. We have hyperbaric oxygen, which may or may not work much. When someone has really bad radiation side effects, we always pull up pentoxifilin and vitamin E because that's pretty much all we have. And I'll say our armamentarium is significantly limited in that regard for things we can do.
All right. I'd like to thank Dr. Cengel very much for this discussion today. I think that
if I can add, I'm seeing a tremendous number of great questions. I don't know if there's any way for me to answer them via e-blast or if it would be possible to write them down and I could get to them, because there's some really great questions for discussion. And I'd really like to thank everyone for participating.
Historically, so this is our first time using WebEx, which may account for some of the confusion at the start. but all of these are being recorded. And what we can do is get together with TRISH, the Translational Research Institute for Space Health, who is sponsoring this program, and we can get you, as well as all the other presenters for this week, any of the questions that we couldn't get to, because I agree, many of them are really great questions. Unfortunately, we just didn't have enough time to cover most of them. So I'd like to thank Dr. Cengel for the presentation today, for taking time out of his day's clinical work to provide this for us. I think this is very useful. And again, please join us tomorrow where we'll be discussing, we're having a round table with Drs. Mike Weil, Guy Gardy, and David Smith, and we'll be discussing radiation platforms at different locations and what are the capabilities. So with that, thank you very much, and we appreciate you joining us today.